Good afternoon. We are going to present in the CCR a case in which it is a lower tracheal stricture, and because of being a lower tracheal stricture, the surgeons were worried that it might be difficult to. Of course, not only the surgeons, we are also worried that we may not be able to maintain the airway once the patient is under anesthesia. And because sternotomy was planned, because ENT people, Dr. Alok, they do it very often, but that is upper tracheal stricture, and there is no need to go into one of the bronchus. So a GA and a securing of airway was very necessary. The apprehension by the surgeons was once uh, that one of the alternative was to put the patient on bypass and do surgery. But because of the risk of bleeding, they were not very keen to do it. And after good pre-op preparation with the pulmonary physicians, it was decided to take up in the main OT without a cardiopulmonary bypass. So today we will be presenting this case. Dr. Abhini, Dr. Vrinda, and Dr. Akhil will be making the presentation. Dr. Abhini.
Good afternoon, everyone. Today, we are going to present a case of cross-field ventilation for a low tracheal stricture. Here, our patient, she was a 22-year-old female. She attempted suicide by hanging in 2017. And she was admitted in ICU, and during that time, she required invasive mechanical ventilation for 3 days. After 2 months of extubation, she developed progressive respiratory distress. In view of that, she referred to AIIMS, and again she required ICU stay and mechanical ventilation. During that time, she evaluated and diagnosed with a tracheal stenosis of more than 80% narrowing. Since then, she underwent multiple rigid bronchoscopy and dilatation, balloon stenting, and on December 2021, stent was removed. After that, her symptoms improved. But again, in January 2022, she presented with a shortness of breath, noisy breathing, dry cough, and she was unable to lie down because of the stridor. She was comfortable only in propped up position. This time she was admitted under pulmonary medicine. CECT was done. In coronal view, we can see a stricture of approximately 2.7 centimeter. The lower end of the stricture was at the level of carina. Vertebral level corresponds to D3, D4. In transverse view, the maximum diameter of the stricture was approximately 4 mm. Fiber optic bronchoscopy done. The glottic opening was normal. At the lower end of the trachea, stenosis was there. Fiber optic bronchoscopy tried to negotiate through the stricture but unable to do. So proceeded with a balloon dilatation up to 7 mm. Post dilatation 5.8 mm fiber optic could be negotiated. Even after this balloon dilatation, her symptoms was persisting. So a definitive plan was made, that was the tracheal resection anastomosis via median sternotomy. Initially, we thought of doing the procedure under cardiopulmonary bypass, but the risk associated with the CPB was more, so plan was made to do the procedure without CPB. Here the patient presented to us. Here our concerns were whether we have to go with awake versus non-awake fiber optic bronchoscopy. In that also we have to see whether we will be able to negotiate the fiber optic through the stricture. Then we have to choose the smaller sizes endotracheal tube. In that case also we have to see whether we have to place the tube above the stricture or we have to negotiate our tube beyond the stricture. And we should have a proper ventilation plan for the time of tracheal resection. For that, we should need a proper PAC. Here, our patient, she don't have any comorbidity, but she was tachypneic with a respiratory rate of approximately 24 per minute. She was using her accessory muscles. She was unable to lie down because of the stridor. She always preferred 30 to 40 degree head up position. Pre-op investigations, hemoglobin was 8.4 gram per deciliter. Rest of the investigations were within normal limit. On the day of surgery, we prepared our difficult airway cart. We arranged smaller sizes endotracheal tube, 5.5 to 6 mm internal diameter, microlaryngeal surgery tube, and flexometallic tube. And different types of supraglottic airway devices, direct laryngoscope and video laryngoscope, fiber optic bronchoscope of both adult and pediatric size. And we kept the jet ventilator standby for the time of resection. And we kept one extra sterile circuit and smaller size flexometallic tube for the time of resection. Standard monitoring and invasive monitoring was done. Then we proceeded with the induction. We kept the patient at 30-degree head up position, and we started pre-oxygenation with 100% oxygen for 3 minutes. After that, we proceeded with the induction with the sevoflurane, oxygen, air, and titrated doses of propofol. Once the patient got induced, mass ventilation was confirmed. After that, injection succinylcholine 100 mg given. And using conventional laryngoscopy, we intubated the trachea with a MLS tube of size 6 mm internal diameter. After that, we did fiber optic bronchoscopy. Under fiber optic guidance, we placed the tube beyond the stricture. This is the video of fiber optic bronchoscopy. Here we can see the tube. As we move, we are able to see the lower end of the stricture and the carina. Anesthesia was maintained with the oxygen, air, sevoflurane, and atracurium. For analgesia, we used IV opioids and paracetamol. Then surgical team proceeded with the tracheal resection. And as soon as the trachea was open, we withdrawn our orotracheal tube gradually up to 15 cm under the guidance of the surgical team. After that, 5.5 mm sterile flexometallic tube was inserted into the left main bronchus, and it was connected to a sterile circuit, and one lung ventilation was started. These were the ventilatory parameters during the time of double lung ventilation and during the time of one lung ventilation, which were within normal limit. We took one ABG as a baseline ABG. Then after that, we repeated the ABG after 40 minutes after initiating the one lung ventilation. These were within normal limit. Then the surgical team proceeded with the tracheal anastomosis. 3 cm strictured segment removed. Then anastomosis of the right bronchus and the posterior wall of the trachea was done during the time of one lung ventilation. After that, flexometallic tube was removed, and the left bronchus anastomosis was done during the time of apnea, which was approximately 2 minutes. After that, anesthesia circuit was attached to orotracheal tube. Intermittent manual ventilation was continued. Entire anastomosis took approximately 40 minutes, and there were no episodes of desaturation during the anastomosis. Intermittent positive pressure ventilation resumed through the orotracheal tube. This is the final image after the anastomosis. Here we can see the anastomotic line. Then this is the trachea, and this is the left bronchus, and this is the right bronchus. Once the surgery was completed, surgical team placed one guardian suture to keep the head in flexed position to relieve the tension on the suture line. After that, residual neuromuscular block was reversed, and endotracheal tube removed in the deeper plane, and it exchanged with the supraglottic airway device. Once the patient was completely awake, she was breathing spontaneously. This airway device was removed by the patient herself. During the entire intraoperative period, vitals were stable and normothermia was maintained. And approximate blood loss was approximately 250 ml, and we transfused one PRBC. Postoperatively, patient shifted to the ICU for the monitoring, and for post-op analgesia, we used IV opioid and paracetamol. This is a photo of our patient. Here we can see the guardian suture for keeping the head in flexed position. Now I am inviting Dr. Vrinda to present the discussion part.
Good afternoon, everyone. I'll be discussing this discussion part. So tracheal resection is basically a challenge for us since it involves a compromised airway. The patient presented to us in stridor, and it is a shared airway during surgery. Anesthetizing a compromised airway may further lead to the loss of airway. And patient often requires prolonged periods of pre-oxygenation in order to have adequate oxygen reservoirs to handle the difficult airway. Positioning of the patient is done in propped up position, semi-sitting position, so in order to avoid the symptoms of the patient. Now, the critical time points throughout were intubation, tube change during resection, the anastomosis phase, and the extubation phase. So, induction can be planned based upon the tracheal diameters of the bronchoscopic findings. According to this algorithm, we chose the middle pathway. That is, the tracheal diameters preoperatively were in the range of 7 to 8 millimeters. So, we gradually anesthetized the patient with using increasing concentrations of sevoflurane along with titrated doses of propofol, followed by which, once we were able to confirm the mask ventilation, we gave injection succinylcholine and then inserted the ETT. So here we used microlaryngeal tube since it has a smaller diameter as compared to the conventional tubes and is also longer in length. So then the surgery was allowed to proceed, and for the open airway phase, cross-field ventilation was done, which will be discussed further. And towards the end of the surgery, we replaced the endotracheal tube in the D plane itself with a supraglottic airway device. Since we didn't want the patient to cough and buck on the tube, since it may lead to the rupture of anastomosis or dehiscence of the anastomosis, so we had put this supraglottic airway device and then extubated the patient. So now the backup plans for intubation were rigid bronchoscopy and ventilation, jet ventilation either through supraglottic or transtracheal route, and waking up of the patient as the last resort. So carinal resection, before opening of the trachea, ventilation is done via orotracheal tube with tip of the tube either above or below the lesion. And after opening of the airway, during the resection and the posterior wall anastomosis phase, one lung ventilation is carried via cross-field ventilation and the anastomosis of the anterior wall is performed. Here we have two options of either advancing the orotracheal tube which was placed initially into the distal bronchus, that is the left bronchus, or performing the anterior wall anastomosis in the apnea time. So this is the image which depicts airway management of the lower tracheal region before tracheal lesion. The orotracheal tube, which was inserted initially, is ventilating both the lungs. Then, during the resection and phase of posterior wall anastomosis, after opening of the trachea, the sterile plexometallic tube is inserted into the distal left bronchus by the surgeon, and one lung ventilation is done through this tube. Then, during the anterior wall anastomosis, after taking out the second tube, orotracheal tube can be advanced into the left bronchus and ventilation can be carried through this tube, or as in our case, we did this anterior wall anastomosis during the apnea time. So the other alternatives for ventilation were low frequency jet ventilation, high frequency jet ventilation, high frequency positive pressure ventilation, cardiopulmonary bypass or extracorporeal membrane oxygenation, spontaneous ventilation or hyperbaric oxygenation. So now I invite our consultant Dr. Akhil for the final comments.
Thank you, Dr. Vrinda. So good afternoon to everyone. As you can see, this was a fairly complicated surgery, which was in hindsight successful only because there was strong and close multidisciplinary collaboration and coordination, which is one of the main takeaways of this presentation, obviously. That any complicated case is never a one-man or one-team show. In an institution like AIIMS, it always involves coordination, close coordination between multiple specialties. Also, the other takeaway is the basic paradigm of anesthesia and generally medicine as well, that you always have to be prepared for any eventuality. Always have plan B, C, and D in your pocket in case plan A doesn't succeed. We were very apprehensive at the beginning of the case, but because of the, in hindsight, good preparation and some amount of with some amount of preparation, we were able to successfully get the case done. I would request Professor Rajendra Prasad to please come up and share his thoughts, if you can, about this particular case.
So first of all, I would like to congratulate the anesthesia team for this wonderful presentation and having taken us through this case. Patient was referred to us from pulmonary medicine, and this lady was repeatedly going into respiratory distress. When she was first admitted in our ward after having been dilated, she was relatively comfortable and she wanted to go home and see her children and all. So we said, okay, go ahead, and then meanwhile we'll also think as to how to go about this problem. Because this is not something which we see every day. Supracarinal stricture, and from our experience of thoracic surgery and otherwise also, we have seen that these inflammatory problems are actually more difficult to treat than a well-defined tumor or a intraluminal tracheal tumor or something like that. So they are actually much more cumbersome and complex problems. So, but within a few days of going back home, she again returned because she developed respiratory distress and she was brought in an ambulance back. And at that point in time, we felt that we have little choice but to kind of go ahead and do. So there were two main problems. One is how to approach this lesion, and second is how to approach this lesion. And of course, the anesthesia part was, of course, a very big challenge. And the option of ECMO and doing it on a bypass, etc., was everything was discussed. So from the approach standpoint, we discussed this case with a lot of people, including people from other parts of the country who are doing these tracheal sections. And also then I got Dr. Alok into it because they have a very vast experience of tracheal stricture and tracheal anastomosis. We thought that it will be very nice to have them with us, and therefore I discussed, and we actually discussed it on 3-4 occasions, on multiple occasions, how to approach, what would be the best way, whether we should go high thoracotomy or whether we should cervical transternal. And eventually we decided upon the combination of cervical and transternal approach, and that I think worked very well for us. And Dr. Alok was there all through with us because they are the ones who do these anastomosis a lot, and uh, eventually we took his help to, we provided the exposure. It was a challenging thing because we have to mobilize the aorta, pull it to one side, mobilize the right pulmonary artery, pull it down, mobilize the SVC, pull it to left, to right, and then mobilize the brachiocephalic artery also. So everything had to be done. So we did request our CTVS friends to be available in case we run into problem, and they were very kind to be available. One of their SRs was there in OT, although we fortunately did not need them, but they were there in case we run into a problem. So with God's grace and help from everybody, eventually we managed it. She had immediate pre-op bronchoscopy done by Dr. Alok's team also, just to make an assessment as to how. There was also a little bit of a debate whether we should try to cross the stricture during intubation or we can leave it above the stricture. Our view was that we can kind of keep it up and proceed, and but I think given the experience Dr. Alok and his team has, they felt it, if we can somehow go across, it may be safer from that standpoint. And eventually, with everybody's effort, patient did well and went home. Thank you very much.
Thank you, sir. Professor Tucker, would you like to come up and please?
I think this particular patients have been a great advance on our practice with tracheal resections or with tracheal stenosis because we have crossed one big barrier. We have built great surgical expertise over the years with regard to dissecting and anastomosing inflamed or stenosed parts of the trachea, but the challenges in the lower airway are so significant both to the anesthesiologist and to us because we have difficulty with exposure, and of course anesthetists have such great difficulty with the confidence. But this patient went like clockwork primarily because of great coordination which was initiated between all teams from the very beginning itself. Everything was planned. We had dilated the stricture. We knew what to anticipate. The plan as to how to get the tubes in was totally sorted. Backups were in place. Surgical access was exceptionally well done. And because surgical expertise for resections and anastomosis has been built in, so it was quickly undertaken, quickly done, quickly executed. So all went well. And of course, the credit is that we could work together so well. So yes, thank you. Congratulations to everybody there.
we'd like to take any questions if the house may have any.